Case number 6, male patient, 55 years old, accidentally discovered to have antral mass 22 by 23 by 25 millimeters during checkup by abdominal ultrasound and CT abdomen, and was confirmed by upper endoscopy. EUS revealed small regular hypoechoic prepyloric mass 18 by 20 millimeters, likely lipoma. Other possibilities are GIST and pancreatic cyst. EUS fine needle aspiration was done, but the biopsies were not adequate for examination. For another EUS and fine needle aspiration was Professor Dr. Hussein Akesh.
Hi, Professor Hakan. This is Mohammed Naguib with you. How do you do?
Yes.
Can you hear us, Professor Hakan?
You hear?
Professor Hakan,
You hear me?
can you hear me?
Is it working?
Yes.
You hear?
Okay.
Yes, this was
Yes.
the first question that I'm going to ask.
Okay.
Thank you, Professor Ansari.
لا بس اتاكد ان ده جاي صوت
ladies
بس.
and
Professor
gentlemen,
Hakan, can you hear me?
I can hear, but you hear me?
So
No?
probably we will need to raise the voice coming to us from room 3.
شوف.
Can you
لا
hear
لا
us, Professor
لا ده
Hakan?
ولا ده سامع؟ ده سامع كويس؟
We are.
Yes, now we can hear better,
سمع-
Dr. Hussein.
سامعني انت دلوقتي يا دكتور محمد؟
Yes, we can hear you, Professor Hussein.
طب
And
مش سامع دكتور هكان؟
You hear me?
and his voice is very, very low voice. We can't hear very well. Okay, the first obvious question from the presentation, that during the presentation, the previous EUS report mentioned that this lesion is hypoechoic. And in the conclusion, they suggested lipoma. And I think none of us here are approving to put a lipoma as a possibility for a hypoechoic lesion. So what is your opinion and the opinion of Professor Hakan? Can lipoma be hypoechoic lesion?
Actually, I agree with you. Lipoma in probably 100% of the time is a hyperechoic lesion. So if it is isoechoic and
So it's unlikely to be lipoma, yes?
yes, so only lesion, subepithelial lesion, which is totally hyperechoic, is lipoma. But sometimes some types of other tumors may be confused with lipoma. In this case, there is a truly subepithelial mass in endoscopic view. You can switch to endoscopy, yes, okay. In endoscopy, we see a truly subepithelial mass, which is very significant. In some patients which have been referred for subepithelial masses, what we actually find that this is not a mass, but impression from either gallbladder, spleen, or left lobe of the liver, but this is very stable. So in the first place, this is a definitive mass in endoscopic examination. We do not embark on EUS first because endoscopic examination also may give some clues to the nature of the lesion. What we see is that the mucosa covering the lesion is totally intact.
Yes, completely.
Of course, it may happen in any type of subepithelial lesion, but from this view, we would exclude pancreatic rest, because in pancreatic rest, we see there is a crescent-like impression just at the top of the lesion. So in this patient, we would say that in the first place, it is highly unlikely that this will be a pancreatic rest.
So we
In the
exclude pancreatic rest. Yes.
Yes. In the second place, whether this is a lipoma or not, the light reflection actually makes lipoma is highly unlikely.
Yes.
And there is no
But we
pillowing.
lost the endoscopic view, so we would like to see both views together, the endoscopic and ultrasound. Yes, yes, now we can see it.
So
You were saying that you can't say lipoma because of what? Because
so we are left with other types of mesenchymal tumors like gastrointestinal stromal tumor, leiomyoma or schwannoma. In this location, leiomyoma is highly unlikely because leiomyoma is mostly a tumor of esophagus and cardioesophageal region. So in this patient, the most likely diagnosis
gastrointestinal
is
stromal
still
tumor.
gastrointestinal stromal tumor. There is a bilobed pattern, you see even from endoscopy it is apparent, but of course we cannot make 100% sure that this is an gastrointestinal stromal tumor. And after this endoscopic examination, we switch to endosonography with my dear friend Professor Okasha. We are going to evaluate this mass together. And now we see
the layer of origin.
the layer of origin seems to be macellaris propria. And now Professor Okasha is showing you the macellaris propria in the adjacent part. And macellaris propria actually is divided into two parts in the lesion. And the lesion is truly in macellaris propria because we see a part of macellaris propria here, and the other part of macellaris propria just beneath the tumor.
So it's from layer 4.
Yes,
fourth
layer 4, layer 4. And now we are, what we see is that this is an isoechoic to hyperechoic lesion, and it is actually hyperechoic in comparison to the rest of macellaris propria. This is a common feature in gastrointestinal stromal tumor. In leiomyoma, the lesion is either isoechoic in comparison to macellaris propria or hypoechoic. But here it is hyperechoic, so it suggests a gastrointestinal stromal tumor. We do not see characteristic cystic spaces which would suggest a malignant transformation. So at this stage, that may be a cyst, a benign cyst, not with malignant transformation. Now we are going to apply Doppler examination because these type of tumors are usually vascular tumors. We are applying power Doppler, and in power Doppler what you see is that there are vascular parts. So it further supports our diagnosis of gastrointestinal stromal tumor. But some other features of gastrointestinal stromal tumors are not present here. This is one of the features is a hypoechoic rim. This hypoechoic rim is not present, and there is no cystic spaces. So in this 25 millimeter lesion, we would say that this is an benign cyst. Actually, subepithelial lesions of esophagus, stomach, and duodenum are challenging issues. And you see that we are deciding about endoscopic resection or surgery mostly according to the EUS findings. If you review large series of gastric resection, endoscopic resection of gastric lesions, you would see that the lesions are mostly lipoma, pancreatic cyst, leiomyoma, granular cell tumor. So it means that mostly the very effort-intensive procedures are done for the lesions actually does not require any type of resection. So it means that if we make a correct diagnosis with EUS, that would save us from some costly and effort-intensive procedures. And yes, please, Professor Okasha.
Excuse me, what we are discussing before the case, that a trick that may deceive many of us is that someone may say that this is the muscularis propria here, and it is going well behind the mass.
Yes.
So if we consider this the muscularis propria and consider this the muscularis mucosa, yes, here, you see with me, if we consider this the muscularis propria and we consider this the muscularis mucosa, then the layer in between will be the submucosa. Then it may we
احنا يا
may
جماعة
think
هنوزع
that
البريك
this lesion originates
واحنا
from the
قاعدين.
submucosa.
Okay.
But if we consider this the muscularis mucosa,
Yes.
and this is the muscularis propria,
And
this is part of the muscularis propria, and this is another part of the muscularis propria, then the lesion will be originated from the muscularis
yes,
propria.
and I think that is the true way of assessment, because we see here the submucosa,
submucosa, yes.
but submucosa is narrowed here in comparison to the other part of stomach. That is because the lesion is actually compressing the submucosa, and because here submucosa is larger, here is narrow. And there are features which suggests gastrointestinal stromal tumor over lipoma here are that it is originating from the fourth layer, it is hyperechoic in comparison to other part of muscularis propria,
Okay.
but it is not as hyperechoic as a lipoma would be.
Professor Hakan.
Yes.
I have two questions here from the
Yes.
floor. The first one is from Professor Ansari. He was asking if you inject some water, would it make it better for us to delineate the layers and the origin of the tumor and assess it in a proper way? Injecting some water?
Actually, what I believe is that here filling with the water would not do much help, because we can delineate the levels, I mean the layers very good in this position. So I believe that water injection, filling the stomach with water, would not do some additive, would not be some additive value. That is
Okay.
my thinking.
Okay, the second question from the floor, they were asking about the management of such case, especially that it was accidentally discovered during routine follow-up or check-up, and that the tumor is 2.5 centimeters. So would you please sum up the algorithm for management for such cases, because not all of the audience are oriented with the current guidelines for management of such a case?
That's a very good question, but very difficult question to answer. Actually, that is a very controversial issue at the moment. Mostly surgeons believe that gastrointestinal stromal tumor is a pre-malignant lesion, so it should be resected anyway, even if it is very small. But what appears is that most of these lesions are not progressing into malignancy. So the treatment, I mean the management, should be individualized and should be discussed with the patient. For gastrointestinal stromal tumors less than 2 centimeters, the risk of malignant transformation is very low. So this patient would undergo some sort of follow-up, like endosonography or CT.
But what is the period of follow-up?
Sorry?
Period of follow-up.
The period of follow-up must not be less than 1 year. So
Okay.
1 year follow-up is okay.
Okay, so less than 2 centimeters, follow-up after 1 year.
After 1 year. But
Okay.
even between 2 and 5 centimeters, what I see in my personal experiences that some of these patients are rejecting surgery, the lesion is remaining in the same size. So we should explain the patient about surgery, but I think we need more data, because for the lesions over 2 centimeters, mostly these are resected, and we do not have a natural course assessment. This is considered as unethical. And because of this, we do not know what is happening to what would happen to patients with 2 and 5 centimeter if they are followed up without any type of treatment. I think this is needed because the general assumption, the paradigm that these lesions are pre-malignant and should be resected if they are over 2 centimeter is too arbitrary, because most of these patients would not progress to malignancy. And as I said, there is no algorithm, it should be individualized. For example, for such a patient, 2.5 centimeters,
Yes.
and there are no features suggesting malignancy, the best way is to follow up this patient.
Follow up or
Another
take a
question.
fine needle aspiration
yes,
biopsy?
Yes, fine needle aspiration, of course, is a necessity. It will further boost our assumption. If we do not find anything suggesting malignancy, then we would follow up safely. But the problem with the fine needle aspiration of these lesions is that in some patients the result is a dry tap. So you perform biopsy several times and the result is nothing. This is one issue. The other issue is that in these samples, sometimes to assess for CKIT is a bit difficult. So they say that yes, this is a mesenchymal tumor, but differential diagnosis is not possible. But in any case, if we perform a diligent biopsy, it is better than not to perform any biopsy. Now we are going to perform biopsy for this patient. So final answer to your question is that the general algorithm dictates that if it is over 2 centimeters, it must be resected. But my personal belief is that an comparative study comparing the natural course with surgery is needed. Another issue is endoscopic management. Now there are some endoscopic techniques, full thickness resection for colon, but yet we do not have any full thickness resection technique for upper gastrointestinal lesions. But as far as I know, the company which is producing the over-the-scope clip is now developing a strategy, a device for the resection of these type of tumors. If these are available, that would be a very good development. Actually, for the colonic, they have a full thickness resection technique. For one patient, I tried this technique for gastrointestinal stromal tumor, but I failed because in colon it is not difficult to suck the lesion into the cap, but for these lesions it is very difficult to suck into the cap because it is a muscularis propria, it is outside, so you cannot resect it completely. Maybe the newest technique our Chinese colleagues are trying may helpful, but they are also reluctant to administer these tunneling techniques for gastrointestinal stromal tumors because there is a general belief that if you impair the patency, the capsule of gastrointestinal stromal tumors, it may put the patient to the risk of metastasis afterwards.
Okay.
So this is a controversial issue, and we need, I think, natural course studies, and
We
I
need
think
a
this would be
consensus for meta-analysis of the studies about that.
yes, surely. Now we are going to perform biopsy from this lesion.
Okay, there is a
20.
question from Professor Ansari.
Professor Hakan, you are welcome in Egypt once more, and we are happy to be with us. I would like to ask the differential diagnosis in such a case. Could we put schwannoma and neuroendocrine tumor in the list of differential diagnosis in such a case?
Actually, it does not seem to be a neuroendocrine tumor because in stomach, neuroendocrine tumors are generally diagnosed by endoscopic biopsy. If you perform endoscopic biopsy, generally you can get positive result. And these are mostly below 2 centimeters, and their appearance is less, I mean more hypoechoic, not like this, less hypoechoic, I mean these are truly hypoechoic. and they are originating from the submucosa, not from macellaris propria. So if the lesion is originating from third layer, then you will suspect neuroendocrine tumor. But for such a lesion which is apparently originating from macellaris propria, we cannot put neuroendocrine tumor into differential diagnosis.
Finally,
Another question, Professor Hakan.
Sorry?
Another question from the floor.
Yes, please.
Yes, they were asking about, is there any rule for elastography to differentiate between a benign or a malignant cyst?
Actually, elastography specialist is Professor Okasha, so I think he is the best person to ask this question. What is your opinion, Professor Okasha?
there are many papers in differentiating benign from malignant cyst. Now, there is no benign and malignant cyst. It is a cyst with variable malignant potentiality, very low, low, intermediate, and high. There are some papers to differentiate between high-grade malignant cyst and low-grade, but these papers, unfortunately, is not so accurate, and so I think the role of elastography in determining the malignant potentiality of cyst is not so accurate, so we depend on fine needle aspiration rather than elastography.
Okay, thank you, Professor Hassan. What type of needle are you going to use,
22.
Professor?
22. We are
The
using
22
22 gauge needle.
Eco-tip,
Yes.
not Proco.
The 22 gauge needle.
Now we are going to put a syringe here.
Okay,
No suction.
Okay, we
Suction,
can see
yes.
the needle now traversing the tumor.
The needle is in the tumor, you see. We are performing
Okay, and how many passes you go through the tumor and
at least 20, I mean I am going to probably do 1 or 2 pass and at least 20 to and pro movement.
Professor Hakan,
Yes.
from the movement of the needle inside the tumor tissue moves with the movement of the needle.
Yeah,
You
yeah.
have the impression that it is a soft tumor,
Yeah.
so lipoma may come back to the
Yeah.
differential diagnosis or not yet, because cyst is a firm one. We don't observe this movement of tissue around, so
Yeah.
you are dead sure that it is cyst or still a lipoma is a second possibility.
Yes, actually you are completely right, because you see that when we put the needle, this lesion is moving with the needle, so a soft one. I agree with you. So I think we should wait for the result of the biopsy. But you are completely right that the lesion is moving with the needle, so it increases our suspicion about gastrointestinal stromal tumor.
okay. So the biopsy seems to be that the needle is going so softly into the in the mass.
Sorry?
Yes? The needle looks going so softly and smoothly into the mass. Yes?
Yes, now we are in the mass.
No, I mean the needle is passing through the mass so softly and so easily, as if it is a soft tumor.
I can't understand.
He impressed that it is a soft tumor.
Yes, this is a soft one, but of course, even if it is soft with needle, it does not exclude a stromal tumor still. Actually, some features of the tumor are really confusing.
Yeah.
But never we decide with the softness or hardness of the tumor with our impression with needle. So that is not such an assessment way. That is highly individualized. So I think we cannot go on with such an assessment. But now we see that actually better the macellaris propria is continuous with the tumor. Do you agree, Professor Okasha?
Yes, yes. I put a lipoma the second possibility.
Yes, yes.
We cannot totally exclude it.
But when we push it with the needle, you see we are pushing macellaris propria.
Yes.
So it means that, and the surface part of the tumor is also coming with this pushing. So it means that this is originating from muscularis propria. But these are very, very individualized methods of assessment. So you cannot put this kind of assessments into scientific scrutiny. For example, you would not say that, oh, I am feeling soft, so this is something like this, or I am feeling hard, this is something like this. This is highly individualized, and it is very difficult to put this kind of assessments into scientific scrutiny. So because of this, we should still rely on established assessment methods. But at the end of the day, you see in most of these assessments, the diagnosis is at the discretion of the physician. So it should be individualized. In any case, all the features would suggest an gastrointestinal stromal tumor, but you would end up with lipoma. It may happen. So you must be open for critics from other people. And my impression is that all the endosonographic features are commensurate with gastrointestinal stromal tumor, but I don't think this is lipoma, but we are going to wait for the result of the pathology, and I think that if the result is still inconclusive, what we are going to do is to put this patient into surveillance and to examine 1 year later. That would be the best strategy. And actually, I agree with Professor Okaka that in most of these circumstances, we are yet to have very well established criteria to diagnose and follow-up of the patient. As I previously said, if you look at the papers about the endoscopic resection of the subepithelial masses of stomach, these are mostly lipoma, pancreatic rest, even leiomyoma, so it means that there are some difficulties in diagnosis. Otherwise, they wouldn't have removed such kind of apparently benign lesions. We completed nearly biopsy, and now we are going to check it. But you should believe me that the biopsy would not be 100% conclusive. So at the end of the day, we are going to decide with our clinical acumen.
Does
So-
the presence, Professor
Yes.
Hakan, does the presence of an on-site cytopathologist better in such cases, or it doesn't make a difference
For on-site, I think it does not make any difference in such cases.
in such
So-
cases? Okay, what about the immunohistotyping and the using of CCAT and other markers?
Sorry, I couldn't get your last question.
The usage of markers, the markers. CCAT,
Markers, such as what?
117 and
Yes, the
34,
CCAT 117 and 34.
Of course, for SECIT, the so-called SECIT assessment is necessary, immunohistochemistry. But the problem is that sometimes it is not possible to achieve cell block. In this case, if you do not have cell block, assessment for immunochemistry, histochemistry may be difficult. But in most of the time, we will get some cell block. Did you examine the sample?
Yes.
Is
enough
it
sample,
okay?
Enough sample. We will.
Is
now
there cell block?
cell block? T cell block. Some. There is cell block. Then we will shift. I think they want to shift to room 2, room 4, with Dr. Michael Hefner.